Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Special Considerations, Episode 4, Medical Decision Making for the Minor. After viewing this episode, participants will review issues regarding consent. Participants will review who can make medical decisions for the minor. Finally, participants will review implied consent.
The minor, the final decision maker, for the most part, is still the parent. And we basically have to respect the parent's opinion, and we have to usually assume that the parent has the best interest of the child at heart. There are exceptions to that. The most obvious, blatant exception is when the pre-hospital care provider believes, they don't have to be sure, but they believe that the child's life is at risk, such as whether it be child abuse, whether it be sexual abuse.
The age that a child can be responsible to themselves in New York State is recognized at 18, except in some special circumstances. If you are seeking care for reproductive or mental health, teenagers are allowed to make that decision without the consent of their parents. If you are pregnant and the decision process is around your fetus and yourself, you can make those decisions less than 18. And once you are a parent, you are considered emancipated and can make those decisions for yourself and for your child. We've done a lot of reading in our department here about what constitutes a minor and what the age of consent is, and it gets complicated, but really 18 is the age to which a child is considered an adult and able to consent for themselves, except for some special circumstances.
It depends on their emancipation level, which is a legal area where they may become emancipated because they have a birth of a child if they're not being cared for still by their mother, or living with their parents, or being supported financially. So emancipation can be at a younger age than the legal age limit. At age 18, they're legally able to give consent or to refuse care, unless those other parameters are present. At younger ages, there's implied consent if the parents aren't available, if they're less than 18 or not emancipated and they need consent for care. That's covered under the implied consent legal terminology.
Assuming responsibility for a minor if the parent's not available becomes complicated. At the hospital, we make every effort to either speak to the parent or the guardian of a child to get their telephone consent for treatment, and then have them identify who it is they trust for a safe discharge. We generally do not discharge teenagers to other teenagers. We don't send them home with their brother unless we've already spoken to the parent. Only the parent or the legal guardian is able to give consent of a child, and that includes children in foster care. For the majority of children in foster care, their foster parents are not their medical guardians. Their own parents are, and we have to involve caseworkers.
If the parent's not available either physically or by telephone, we go to all efforts to contact the parents, whether they can be present or not. They're generally, in most cases, in the care of somebody at the time, a caregiver, babysitter, relative, friend, while the parents are not currently present. And they generally can guide you as far as how to contact the parents. Police obviously can be of assistance in that area. But as far as legally being able to care for the patient, that still falls upon the parent or the designated person that has custody or care of the minor at that time.
Patients under the age of 18 require parental consent for medical decisions unless emancipated. Situations which may exempt parental consent include proof of emancipation and signs of abuse.
Implied consent. Well, in a hospital or an EMS situation, if a child's in distress or injured, implied consent takes precedent. If a child, you want to give them care that is going to intercede on them becoming worse. And a good example would be if you went on a call to a school and you had a patient who was having an asthma exacerbation and really was working hard to breathe and needed a nebulizer treatment, but you hadn't spoken to the parent. The likelihood that the parent is going to give you consent for this is very good, if not 100%, because the increase of this asthma attack could lead to the respiratory arrest and ultimate untimely death of a child. So implied consent, if there's something you can do that isn't totally invasive in the field, you go ahead and do it. In the hospital, we do complete invasive events if there is risk to limb or to life without the consent of the parent. If you had a trauma that was flown in here and the kid needed to go to the OR, now they would go now. Implied consent takes the precedent that the family would want something done here.
Implied consent is basically exactly what it says. If consent is not available and treatment is important to be done or transport is needed to a medical facility, it's implied that the parent would want that type of care being offered to the minor patient. So that's used in the absence of parental consent or presence. A lot of times if the patients, in adults it's also used, for unconscious patients, you would assume that they would want care. So the same parameters fall with pediatric population, where you would assume that the parents would want the child taken care of in their absence.
Implied consent is used in situations involving minors when the parents are not available to provide consent. In cases of life or limb, it is implied that the parent would provide consent for procedures.
Here at the hospital, we run into a lot of problems with consent for minors. We'll have a 16-year-old show up sick as stink, and the parent didn't feel like bringing him to the hospital, so the kid got on the bus and came. So we want to treat the kid, but we need the parent to know for two reasons. One, they are their guardian, and they should give consent for the child. But the other is, we need a safe discharge for that child, and we need the parent to have the plan.
Generally, I haven't really run into too many cases where the parents refused care for a patient who really needed it. Again, it depends on, a lot of times, your demeanor and your persuasiveness to advise the parents of the need for transport or treatment of their child. And a lot of times it's just that educational point that they need to realize that things do need to be done as far as interventions in the pre-hospital arena and transport to the hospital for follow-up care. I haven't really run into too many situations that consent's been refused when it's obviously the interventions need to be performed. So again, if you run into the situation, law enforcement sometimes can be helpful. And a lot of times, like I said, just a professional demeanor and educating the parent, even if it takes 30 seconds or 2 minutes to do, sometimes it's worth the time to explain what needs to be done and why to the patient, to patients' parents or custodial personnel, as far as understanding what needs to be done. And generally, consent's not generally an issue.
Making medical decisions in the minor can be difficult. Ultimately, the decision falls to the parent unless there is proof of emancipation. Parents should be contacted. A phone conversation is acceptable, however, in-person interaction with the parent is preferred. In cases of a life or limb, emergency procedures may be provided without consent under the guidelines of implied consent. After viewing this episode, participants will review issues regarding consent. Participants will review who can make medical decisions for the minor. Finally, participants will review implied consent.